Good day, students. Meeting you after a long time in G.A.M.E. Gross and microscopy explained. I am sure you people will be able to identify the two pictures on the screen. The lesion for the day will be tuberculosis and typhoid ulcers of the intestine. These can be kept as specimens for you people, and I have also given the other relevant importance within the enclosure. And this is the reference for you people in rats. Coming to tuberculosis of the intestine, there are two intestinal lesions in tuberculosis. One is ulcerative, the other is hyperplastic. Some books give the third lesion as ulcero-hyperplastic or ulcero-proliferative. But we shall remember these two for the time being, ulcerative and hyperplastic. This is a mounted specimen of the intestine measuring so many centimeters long. You are supposed to measure each specimen and then write it down. The external or the serosal surface is grayish brown with a few small nodules. Please look for these, you may or may not see them. The mucosal surface has got multiple ulcers. So this is the region of the ulcer and these are separated by normal mucosa. I am able to see the mucosal folds in these regions. And there is also another ulcerative lesion over here. The arrow points to an area of constriction which is characteristic of tuberculosis. This is a classical specimen I had already shown to you people in the rats. Again, a part specimen of the intestine measuring so many centimeters long. The external surface is pinkish brown and it may show a few nodules. Kindly look for it. If there are no nodules, just leave it as unremarkable. There are two ulcerative lesions which are marked by the white arrows and they measure so many centimeters by so many centimeters in dimensions. They are separated by multiple mucosal folds of normal intestine. The floor of the ulcer is grayish white in color and the ulcer is quite shallow. The surface is flushed with the surface of the surrounding normal mucosa. The long axis of the ulcers are perpendicular to the long axis of the bowel. For example, if this is going to be the long axis, it is perpendicular to the long axis of the bowel, which is characteristic of tuberculosis. Why this happens is because there is always a circumferential rim of lymphatics. From here, there will be a circumferential rim of lymphatics along which the lesion spreads. Therefore, the lesion is also circumferential with the long axis perpendicular to the long axis of the bowel. The wall is firm in texture and that is because of fibrosis. And the lumen is constricted in these regions. I am able to see a constriction here also because of fibrosis. So remember these words, shallow ulcers, long axis is perpendicular and it is firm in texture. Yet another diagram, this you people need not write but observe. So there is an area of constriction over here and this is a normal mucosa. The oval-shaped ulcers are perpendicular due to the spread along the lymphatics, which is perpendicularly distributed. And this, of course, will be the histological counterpart, which is generally not given to the students as a slide. Tuberculosis of the lymph node is given, whereas an intestine is usually not given. I am able to see the intestinal mucosa, then a granuloma with caseating necrosis and giant cells. And it is surrounded by lymphocytes. All the dark blue dots are the lymphocytes. So, a very beautiful photomicrograph retrieved from the net. I am able to find a constricting ulcerative lesion surrounded by the normal mucosa. And in this, there are a couple of giant cells, one of which is having a typical horseshoe distribution of the nuclei. This is an example of tuberculous lesion. Whereas in typhoid, look at this one. This is purposely kept for comparison. I am finding in one that the ulcers are perpendicular to the long axis. In this typhoid, I am finding that the long axis of the ulcer is parallel to the long axis of the bowel. Here, the floor is grayish white, but in this I am able to see friable necrotic debris. Here also it will be grayish black in color. The edges are slightly raised in the case of typhoid ulcer, whereas in tuberculosis they are flushed with the surface. A very beautiful picture which you people should remember and register in your minds. Oval ulcers. And why are they oval and why is the long axis parallel? That is because the ulcers are overlying the Peyer's patches and it is parallel to the long axis of the bowel. The floor will be showing necrotic debris. And this is one of the most superb specimens that I have ever seen, and I have given the source in the rats. So this is an ulcer. Again, the long axis is parallel to the long axis of the bowel. What are the usual questions that are asked for the students? Description of the specimen. So it will be kept for about 5 marks or so. Specimen can be kept as a spotter, and the same specimen can be kept for the viva and OC. And when it is kept, different questions can be asked. And what are all the classical differences between the typhoid ulcer and tuberculous ulcer? And enumerate the other ulcerative lesions of the intestine. For example, amoebic ulcer we should have in mind. And have also these in mind. Tuberculosis is an essay question, granuloma is a short note, and primary complex of the intestine you'll have to remember. Typhoid ulcer itself is a question for you people in general pathology. We shall visit it later. And this again you do not write, and this is the shape of the ulcer etc. that has been described, and this is a granuloma showing Langerhans type of giant cells. And to summarize, there is a caseating granuloma in tuberculosis surrounded by lymphocytes. See you in game 17.